Hello, good morning. It's such an honor to be asked to present at this year's Medical Fiesta. I was approached by Dr. Pencil to do this presentation for this year on imaging. Clearly, at the moment, imaging is not a topical issue in Ghana. We have other things, and I'm sure that Fiesta is going to cover most of the more topical issues. But I did also think I'll start off by talking about the important issues in Africa at the moment, which probably is not related to imaging. Obviously, I'm a radiologist and I don't deal with any of this stuff. But then I did find some interesting do's and don'ts for Ebola, and I think that the most important one is that you should not touch a person or an animal who has Ebola, but how do you know anyway? So that's just by way of introduction. For today's presentation, I'm going to be talking about the scope of imaging that is usually presented to non-radiologists. So this talk really is aimed at sort of non-radiologists, but I'm sure these days most doctors have to deal with radiology in one way or the other. So if at the end of this talk you understand the scope of the various medical imaging modalities, and also I'll attempt to introduce what multimodality imaging is, and also complementary imaging concepts, imaging choice in Ghana or globally, and also the current practice, which I'll try to tailor towards Ghana. And also, if there's time, we will talk about future trends. That's a beautiful picture. Anyone knows where that's from? Well, this is actually Iceland, but I'm not here to show my holiday pictures. I'm just here to try and use this picture to demonstrate the importance of multimodality imaging. So when you're presented with when you're presented with a medical problem that you're going to try to solve, so you have the patient sitting in front of you, you need to use imaging, if you do, to try and solve the problem. And I see that as walking from here to the top of the mountain. So to be able to get to the top of the mountain, you have to walk across some dry land, some water, and then you probably need some gear to climb the mountain. So to walk across the water, to walk on the dry land, you're going to need a different equipment from what you're going to use to go across the water and also to walk across the mountain. And that's how we try to see radiology. There are all different modalities, but we use all of them to try and solve a particular problem. So what are the modalities that we have available to us as radiologists? Well, first of all, just going from probably the very basic to the more complex modalities. First of all, plain films. We've all seen plain films. We use them all the time. It's still the bread and butter of much of radiology. Ultrasound, again, very common, particularly here in Ghana, where I think it seems like every corner of the streets you pass, there is an ultrasound or diagnostic center with ultrasound. Computer tomography starts to get a bit more complex and, if you like, more interesting. Magnetic resonance imaging and functional imaging. That's what the F there stands for. It's not a rude word. And then nuclear medicine and SPECT imaging. And I'll probably go through that briefly. Positron emission tomography is also one modality that is increasingly being used. And then you get into the realm of hybrid imaging, where you combine different modalities, all sort of in the same all as one sort of one machine or one equipment, but being done at the same time. And then interventional radiology, which is a whole different subspecialty. But I've got a few slides on that as well. Well, now you can't talk about any radiological procedures or to choose a particular procedure. Of course, you're going to try to choose the best procedure for the patient, but you also have to consider cost. And even in developed countries, cost implications are still considered in choosing the appropriate procedure for the patient. And by and large, most doctors will start with the cheaper modalities and obviously work your way up to the more expensive or the more technically advanced procedures. And just to give you an idea of the different costs that we're talking about, obviously this is in pounds, because obviously that's what I'm used to. But then from the Department of Health in the UK, these are the costs that have been ascribed to the different modalities. So plain films are by far the cheapest, ultrasound, and then in that order, CT scan, MRI, and the PET scans are the most expensive. Interventional radiology will be much more expensive because then you're using different equipment and also lots of disposables. I'll just rush through this a little bit just to get to the images so that we can learn a bit more of radiology. This is more of the administrative type of it, administrative side of things. Right, now, also before you request a particular test, what we find is when the junior doctors start in our hospitals, they have difficulty in sort of deciding what test is appropriate for what particular condition. And but before you actually request any test, there are a few questions that need to be asked. First of all, is the test actually required, and will it alter the patient's clinical management? And then if you feel the test is required, then you need to ask yourself, of all the different modalities, which one would answer the clinical question in the most safe, and as I already pointed out, cost-effective way? And then from there, you obviously go ahead and order the test. But then to order a test, it's always important to provide adequate clinical information for the radiologist who is going to report your test for you. I mean, moving on to that, to be able to make the most effective use of these expensive equipment and expensive modalities that we have at our disposal, we need to know also if a test has already been done or not, because you'll be surprised the number of times that the test has been done, and then doctors will go ahead and reorder the same test, or even a test, it may be a different modality, but trying to answer the same question, duplicating the test, and obviously increasing the cost for everybody. Also, do I need it? Do you really need to have the test? You know, not everybody who is coming with a particular medical problem needs to have a test. Obviously, this is where the clinical information comes in. And do you need it now? Will the patient's condition improve if he doesn't have the test now? And if the condition was going to improve anyway, do you really need to have the test? And is it the best investigation? We've already gone into it. And by investigation, it's not just radiological investigation. Could a blood test probably be more appropriate, or other laboratory investigations? And then have you explained the problem, which goes back to what we said before. Have you provided clinical information? Have you actually explained the problem to the radiologist who is going to read the test? And then when the report is issued by the radiologist, are you going to read it and are you going to act on it? It's very important. But frequently this doesn't happen, unfortunately. Right, starting off with ultrasound. We're all familiar with ultrasounds. We've all seen these sort of images. Some of us may have had ultrasounds in the past. But then I've put side by side the sort of different types of equipment and how we're sort of almost downsizing the ultrasound machines, because ultrasound is becoming more and more useful, not just in radiology departments, but by the patient's bedside as well. So that's what that slide is for. But when is ultrasound most useful? Ultrasound is actually most useful when we're dealing with soft tissue imaging. We don't use ultrasound for bone, and ultrasound isn't used for bowel either. And there are a few advantages with ultrasound. By far is that it's got no radiation as opposed to other imaging modalities, and we'll go through that. The other advantage with ultrasound is that in addition to the grayscale images, you can have color imaging. And color imaging is to assess ultrasound from the color flow, blood flow point of view, which really makes it in ultrasound. From an ultrasound image, what you get is several shades of gray, sort of a very wide spectrum of sort of from the very dark to the very bright, and in between that you have several shades of gray. So where you have the very dark structure, in ultrasound we refer to that as hypoechoic or anechoic, and that usually would reflect fluid. So we've got a fluid containing structure there with a bright structure within it, and the bright structure we refer to as hyperechoic. So we've got a hypoechoic structure containing a hyperechoic material within it. That structure there, as some of you might know, is a gallbladder, and that is a gallstone. And whenever you have a very hyperechoic structure, just beyond it, the grayness, if you like, is much reduced, and that is what we call an acoustic shadow. So this is this image does show quite a few important, quite a lot of terminology in relation to ultrasound, and some of the principles of ultrasound are demonstrated quite well in this image. So what we have there, so we have a gallbladder containing a gallstone with acoustic shadowing, and then we've also measured the structure here, which is the common bile duct. So we can see the structures at the hepatic portal, the common bile duct right there, and then this just behind the common bile duct, if you remember from your anatomy, is the portal vein, and then we've got the hepatic artery there, and then anybody knows what this is? It's another very important structure traversing the liver. It's obviously a bit more posterior than the structures in the hepatic portal, and that is the IVC, which is the inferior vena cava. Right, so it just shows very, very interesting how clearly you can sometimes see ultrasound, and if you got your anatomy right, you can understand and As opposed to ultrasound, where you have a wide spectrum of different densities. With plain films, you only allow 3. Yeah, you can't. There's bone or anything containing calcium, soft tissue, and air. You're not allowed anything else to talk about any other densities other than that. Unfortunately, some plain radiographs are now extinct. We hardly ever perform them. Skull X-rays, maybe in Ghana we might use them for in the setting of trauma, but in most advanced practices, we hardly use skull X-rays for trauma anymore. KUB X-rays are now being supplanted by CT KUBs, and then sinus X-rays and abdominal X-rays hardly performed because of CT again. Now, this is one of my most favorite images or slides. Because it looks like, when you look at it immediately, you think there's so much going on there. But radiologists like this sort of thing. We like calcification because, you know, that's how you try and work out what different, where the different calcification or the different calcific structures are. So to start off with, let's just take the simple ones. First of all, there's this very well-defined globular calcification there, just in the right subcostal region. And I mean, the only structure in that region that would take the form, or a calcification that would take the form of a structure, that would be a gallstone. I mean, gallstone would be a structure there that would, the structure would fill the gallbladder, that would take that shape. Now there are other bits of calcification there. That, again, is very pathognomonic really of renal stone or Stockholm calculus, because it's taking the shape of the collecting systems in the kidney. And then I'd like to just spend a few minutes to talk about this sort of calcification, which is called curvilinear calcification. And whenever you see curvilinear calcification, it means it's within the wall of a hollow structure or a cyst, as in this case where you've got kidney cysts, which have calcification within the walls. Okay, finally, we've got this sort of calcification here, which it seems quite abundant. Now, if you follow this up, you follow this calcification up, you go probably into the ribs, yes? So this calcification is actually costal cartilage calcification, which tends to occur as people age. Now, curvilinear calcification, as I did mention, is quite important because sometimes you can come across structures like this. And if this patient presented, say, to accident and emergency, this is somebody that you shouldn't send home if you have this X-ray in a patient with abdominal pain, because this structure is on the left-hand side. You've got curvilinear calcification, so that tells you that it's a hollow structure. And it's, you know, it looks quite big. And if you probably felt the patient's abdomen, you feel pulsations. So that's an abdominal aortic aneurysm, which can rupture. So this patient should be admitted. And what test then would you follow the patient on with? right heart border is formed by the right atrium, and so see you back after your lunch when we will talk about the more advanced imaging modalities available to us. Thank you.